Good morning, good afternoon, good evening, wherever you are. Welcome to Virtual Grand Rounds. Premier Education brought to you at no cost thanks to our sponsors, AstraZeneca, Medtronic, and Medela, the Science of Care. This week, it's a great delight for me to be able to present Professor Paul van Schil from Belgium. Many of you will already know Professor van Schil, currently the president of IASLC, and has great expertise in this area, presenting today about salvage surgery, initially after chemoradiotherapy, and today, as you know, immuno-oncology has taken the field, and that presents a new paradigm and a new area for surgeons as well. Thank you, Paul. Over to you.
Thank you very much, Erik, for this very kind introduction, and it's a real pleasure for me to participate in this grand round. The topic you gave me, it's quite difficult topic, salvage surgery after chemoradiotherapy and immunotherapy. These are my disclosures. When we look at our textbook of thoracic oncology, the second edition dates from 2017, there's only one paragraph dedicated to salvage surgery after stereotactic radiotherapy. They say that there is limited experience, but it is feasible and safe in experienced hands. Also in some patients initially considered to be inoperable. So for the moment, 7 years later, we don't have any precise definition of what constitutes really salvage surgery, and we don't have any guidelines. So what I would like to do is present you 4 cases looking at different extents of resection, which we can call salvage surgery. Then we look at some data on salvage surgery after definitive chemoradiation, which is well documented. Less documented is salvage surgery after stereotactic radiotherapy or combined modality therapy, including chemotherapy and immunotherapy. And then we come to some conclusions. First case is a male patient born in 1965. He smoked 20 pack years but stopped in 21. In 2020, he was diagnosed with sigmoid cancer with a solitary lung metastasis. He was treated with neoadjuvant chemotherapy, sigmoid resection, followed by adjuvant chemotherapy. In 23, he was treated by stereotactic radiotherapy for a lung nodule in the right lower lobe. In February 24, the PET scans showed an increase in the lung nodule. There's some discrepancy between the CT and the PET, but you can see clearly the positive metastasis on the right side, or probable metastasis. So we operated these patients. We performed a wedge excision of the right lower lobe. This was a metastasis of a colon adenocarcinoma. Lymph nodes were negative and section margins were negative. Postoperative recovery was uneventful. On a recent chest abdominal CT in March 25, there was no local regional recurrence, but a new cystic airspace developed in the left upper lobe of 10 millimeters. We performed a VETS excision in May, and this was a primary adenocarcinoma. So this was not a metastasis, as you can imagine from the CT scan. It was a pathological T1A N0M0. The second case is an 80-year-old male patient with a history of myocardial infarction, coronary bypass, and chronic renal insufficiency. He smoked 50 pack years. A lesion was discovered in the right upper lobe. This was considered to be inoperable by an MDT, but no thoracic surgeon was present. He was treated with local high-dose radiotherapy. In 2012, the lesion size increased. The question was this a reactive pneumonitis? And close follow-up was done. The lesion size still increased in 2013. Then he was evaluated for surgery. His pulmonary function was completely normal with a diffusion capacity of 90%. Echocardiography showed a normal left ventricular function, and we operated the patient in 2013. Unfortunately, he had to do a bilobectomy of the right upper and middle lobe because of extension of the tumor. This was pathologically a T2B N0M0 PL2. There were no complications, but the patient died in 2014 of brain metastasis. The third patient is salvage surgery after combined chemoradiation and immunotherapy. It's a male patient born in 1965. He stopped smoking. and his history showed hepatitis B, and in 2011 an Aspergillus infection in the lung. In 22, a centrally located squamous cell carcinoma on the right side was diagnosed. This was clinically a T4N2M0 stage 3B disease. He was treated by chemoradiation followed by immunotherapy. The PET-CT in April 24 showed progressive disease with a tumor in the right lower lobe of a maximum diameter of 8 centimeters, but also encasement of the lower lobe bronchus, as you can see over here on the PET-CT scan. So this is really a centrally located tumor with progressive disease. There was also suspicious lymph node in the right paratracheal region, so lymph node station 2R. His lung function showed a vital capacity of 85% and FEV1 of 79% and a diffusion capacity of 67%. He was referred from another hospital, and discussion at that MDT, they were asking for a salvage lobectomy, but had my doubt in light of the central extension of the tumor. We operated this patient in May 24, but as expected, had to do an intrapericardial pneumonectomy on the right side with a partial pericardiectomy, and because of intrapericardial extension, we had to staple the left atrium. Postoperative, he was treated with intravenous antibiotics because of an increase in the inflammatory parameters. Pathology showed a squamous cell carcinoma on the right side with a diameter of 8.5 centimeters, 75% necrosis, but the lymph nodes were negative. So this was a YP-T4N0M0, so stage 3A. Patient was discharged 2 weeks after the operation. No adjuvant therapy was given. In October 24, he came at the outpatient clinic in good general condition, but unfortunately he died in March of this year because of aspiration pneumonia, and also local regional recurrence was diagnosed. The most difficult case I encountered over the years is this patient. Is a young female patient of 39 years old. She smoked 25 pack years. A clinical T1N3M0 adenocarcinoma in the right upper lobe was diagnosed. PET showed no distant metastasis, so this was a stage 3B. She had induction chemotherapy with cisplatin pemetrexed, followed by radiotherapy 60 grays in 30 sessions. This is a CT scan in April 2007. As you can imagine, in June 2007, there seemed to be a partial response, but follow-up CT scans from September showed an infiltrate in the right upper lobe. So the question was this only radiopneumonitis? Is there a good response regarding the tumor? But suddenly a cavity also developed. And this worsened. Patient was admitted with purulent cough with hemoptysis. An infected cavity was diagnosed in October 2007 with a necrotic lung abscess, as you can see. So we operated this patient. We had to do an intrapericardial pneumonectomy, but because of the fragility of the pulmonary artery, we had to put the patient on bypass because of a tear of the pulmonary artery right at its origin. We also put in an irrigation system. Culture showed fungi, Klebsiella and Staph aureus. And unfortunately, on pathologists, there were multiple nodules of adenocarcinoma in the right lung, and lymph node 7, so the subcarinal lymph node station, was still positive. So this was a YP-T3N2M0. This patient recovered from the operation, but she died 8 months later of bone metastasis. So looking at the literature, salvage surgery after definitive chemoradiation has been very well documented. This, I think, is an important series from Milano, from European Institute of Oncology. Casiraghi is the first author. So 35 patients with lung cancer recurrence after definitive chemoradiation consisting of cisplatin-based chemotherapy and 58 grays of radiotherapy were treated between 2003 and 2013. There were 6 exploratory thoracotomies, so 17%, meaning open and closed thoracotomies, that the tumor was unresectable. 29 patients had lung cancer resection, but in 17 cases, a pneumonectomy was necessary, 7 on the right side, 10 on the left side. Lobectomy or bilobectomy could be performed in 12 patients. In 13 patients, extended resection were necessary, meaning an intrapericardial resection of the superior vena cava, trachea, or chest wall, besides the lung resection. R0 resection was obtained in 77% of the cases, and the median time of chemoradiation to resection was 7 months, with a range of 1 to 39. And as can be expected, viable tumor was found in 90% of the patients. 2 patients died with a 30-day mortality of 5.7%. 9 patients had major complications. After median follow-up of 13 months, 3-year survival after R0 resection was 37%. So these are quite difficult cases, but it was concluded that salvage surgery after definitive chemoradiation was feasible with acceptable complication and survival rates. This is a cumulative analysis of 9 studies of 200 patients who were treated with definitive chemoradiation. Persistent disease was present in 47% and local regional recurrence in 52%. The time from radiotherapy to resection varied from 3 to 282 weeks. Lobectomy in this large study was performed in 63% of the cases and pneumonectomy 28%. Morbidity was 41% and mortality 4%. Median recurrence-free survival varied between 10 and 22 months, with an overall survival 13 to 76 months. Favorable prognostic factors in this study were a longer period from radiotherapy to resection, a radiological downstaging, and pathological response. Regarding salvage surgery after stereotactic radiotherapy or combined modality therapy, this is a study showing that also emergency salvage lung resection can be necessary. Time period is between 2015 and 2020, published in 2022, of 10 patients, but they consist of only 1.2% of the primary lung cancer interventions. Chemo-radiotherapy was given to 5 patients, chemotherapy only to 4, and 1 patient was treated with proton beam irradiation. Indications were a lung abscess in 5 patients, combined with hemoptysis in 3 patients, hemoptysis only in 1 patient, and 1 patient was treated because of empyema. Lobectomy could be performed in 8 patients, bilobectomy in 1, and pneumonectomy also in 1. Mortality was 0%. Severe complications occurred in 3 patients. Median survival time postoperative was 9.4 months, and from the initial treatment, 19.4 months. So they concluded that those are technically challenging procedures with palliative intent, but still feasible. This is a series of 932 patients who were treated with stereotactic radiotherapy during a 10-year period. 48 patients had local recurrence, 5.2%, and 2% of the cases, so 19%, underwent salvage surgery. Lobectomy could be performed in 15 patients. Postoperative complications were rare, 2.1%. Stage progression, this is important, I think, was noted in 7 patients or 37%. The 5-year disease-free survival was 65%, and overall survival 72.5%. So salvage surgery after stereotactic radiotherapy, usually for peripheral located cancers, was considered to be safe. And when you perform complete resection, as general is true for lung cancer resections, you have a good prognosis, but careful selection of your patients is necessary. And one of the largest series, the last series I want to present you, is published in the Journal of Thoracic and Cardiovascular Surgery in 2024 by Dr. Dunay. They included patients from 2010 to 2022, so 120 patients. The initial clinical stage was early in 16%, local regional advanced in 25%, and metastatic in 59%. Initial therapy consisted of radiotherapy in 39%, stereotactic radiotherapy was given in 32%, targeted therapies were given in 45%, so this is one of the first series looking at that, and immune therapy in 17%, so rather limited regarding the experience with immune therapy. Indications for surgery were recurrent disease in 18%, local persistent disease in 23%, oligoprogression in 22%, and local control of oligometastatic disease in 38%. So quite a variety of indications for salvage surgery. Surgery consisted of wedge resection only in 19%, lobectomy in most of the cases 67%, bilobectomy in 5%, pneumonectomy 4%, and exploration only, so open and close thoracotomies in 3%. R0 resection could be obtained in 88%, complications grade 3 or higher 5%, and 90-day mortality was 3%. The 3-year event-free survival 39% and overall survival 73%. And you can see the survival curves on the right side. A lower event-free and overall survival were related to male sex and lymphovascular invasion. A lower overall survival also in younger patients and those having prior radiotherapy. But of course, this is not a randomized study. So when you apply salvage surgery for stage 4, you have a better overall survival compared to systemic therapy and no surgery in this series. But again, those are highly selected patients who underwent surgery. So surgery was considered safe as local consolidative treatment with encouraging outcomes. So regarding the conclusions, for the discussion, I include this figure, which I found in a recent paper in Cancer, looking at salvage treatment. So if you start with neoadjuvant immunochemotherapy and you have good response or stable disease, you can apply surgery, as shown on the left side. But I don't really think this is salvage surgery, but usually surgery is considered at the initial treatment plan of the patient. When you have progressive disease and it's localized and resectable, you can perform surgery. When this is not the case, usually chemoradiation followed by immune therapy is given, according to the Pacific trial. And then in case of metastatic disease, when it's oligometastatic, you can consider salvage surgery as local treatment together with the systemic treatment. When it's not the case, further immune therapy, chemotherapy, or chemotherapy alone or targeted therapies can be indicated. So in conclusion, surgery with the cases I showed you after definitive chemoradiotherapy and or immunotherapy can be terribly simple or simply terrible. After stereotactic radiotherapy, radiofrequency ablation, or immunochemotherapy, this is a relatively new entity in thoracic surgery, and at the present time, no specific guidelines exist. We don't even have a precise definition of what constitutes salvage surgery. But to me, it means that surgery is the only option that remains for a patient after chemoradiotherapy or chemoimmunotherapy. The question is also how to exactly evaluate response after stereotactic radiotherapy, radiofrequency ablation, or immune therapy. We know that CT scan, so imaging, or even PET-CT is not always very helpful in predicting response. So every case should be discussed at an MDT, including a thoracic surgeon. From the series I showed you, mortality, morbidity, and long-term results of salvage surgery are acceptable, but all the series I presented are in fact retrospective series. Those cases should be treated at an experienced thoracic surgical center, and thoracic surgeons should be aware that more technical difficulties may be possible, especially the hilar dissection around the pulmonary artery can be quite tedious, so in some cases intrapericardial control is really necessary. So be prepared for the worst case scenario when you operate on those difficult cases. This is our new port office in the port of Antwerp. You can see it's a magnificent new building built on top of an old fire station, showing that you should combine the old and the new to obtain the best results. And I thank you for your attention.
Thank you very much, Paul, for an amazing overview on what is considered to be a really difficult and challenging topic. Maybe the first question I would like to pose to you is that why do or should surgeons consider salvage surgery in patients who were deemed inoperable from the outset, people with comorbidities, a higher disease burden, um, with undergoing chemo-radiotherapy plus minus immunotherapy, with disease or interval progression and much more difficult surgery? What as surgeons, what are we trying to achieve for salvage surgery in these circumstances? In particular, your patient number two.
Yes, exactly. So every case should be discussed at an MDT. And I think we can consider salvage surgery when it's the only option that remains for a patient that wants to be treated further on, or unless there are complications. For example, when a lung abscess develops or patient has complications. And usually the oncologist, that's sometimes the difficulty that initially the patient is considered to be unresectable, as also done in the Pacific trial, but I doubt whether those tumors were really unresectable from the start. As you know, there's no precise definition of what constitutes resectable or unresectable disease. In all the trials of chemoimmunotherapy, the disease was considered to be resectable, but again, there was no precise definition. And the studies after chemoradiation is considered to be unresectable, but I doubt whether all those cases were really unresectable. So sometimes the patient is referred because they want some more additional treatment when there's a failure of the chemoradiation or the immunotherapy with progressive disease or complications develop. As the last patient I showed you, yeah, she was almost dying because of a septic shock when we operated on her. So those are very different indications to be considered.
Yeah, I noticed that some of the indications, including diagnostic, to find out what the cause or the progression is, preventative for worsening or further complications such as sepsis. And I think probably I agree with you that the most challenging is the therapeutic, whether or not there's going to be therapeutic advances. And in many cases, even in the surgical series, progression is a huge issue of what we can see. We've got a lot of questions from the audience. We're going to start with Dr. Patel, who's asking, have you noticed any association between continuing smokers with the reason not to operate or failure of initial treatment? And also, does it really impact the outcomes of salvage surgery?
Well, we don't have any good data on that, but most of the patients we operated did not continue smoking. They stopped smoking, although there were some that, they were really addicted to smoking and they couldn't stop smoking. That's sometimes very surprising. Even those patients we do a pneumonectomy, they continue smoking afterwards. They cannot really stop because they are so addicted. I don't know whether there is any relation to smoking. We know that of course, we have more complications in those patients who did not stop smoking before the operation or continue to smoke afterwards. But in the series I looked at, there was no real relation between progression of disease and continuous smoking. Although logically, you can expect that there's more progression when the patient continues smoking.
Interesting. We are just doing quite a large series at the Brompton looking at our advice that we give to current smokers. And it's being prepared for publication, but our initial findings is that the complication and outcomes did not increase if patients were not told to stop smoking before their operations.
Yeah.
Often
Yeah.
data is counterintuitive to what we think as doctors.
Yeah, there are
A que
studies showing that you should stop smoking at least 4 to 6 weeks before the operation. That otherwise you increase even the complication when you stop 4 weeks before the operation, due probably to bronchorrhea and more secretions that develop. Yeah.
Yes, correct. But those timelines in the UK are not acceptable because of the waiting lists for cancer
Okay.
surgery. So it is a difficult problem. Question from Dr. Therese. Are there any methods for which we can improve patients' fitness for salvage surgery?
Yeah, that's a very good question also, because I could not discuss it. We looked at the cancers, but we also look at the patients regarding cardiopulmonary morbidity. And in some cases, we try to improve the pulmonary function, the lung function before the operation by intensive physiotherapy. with really dedicated nurses and a program to have a better lung function, and also with some aerosols and puffs that the patients can receive. But that's in collaboration with respiratory physicians and respiratory revalidation. And some patients need to continue the revalidation after the operation to have the best results.
Question from Dr. Akif Turner, who's asking, would you recommend salvage surgery in patients who already underwent definitive chemoradiation for, say, N3 disease?
Yeah, it depends on the response we have. I think those patients need very careful staging. But as I mentioned, I think salvage surgery can be indicated when surgery is the only therapeutic option that remains for especially younger patients. But N3 disease, I would be very reluctant to operate on those patients, especially when you have persisting N3 disease. And in some cases, I know it's not general, but we try to prove it by mediastinoscopy, is that not done before. And when it's really N3 disease, or I don't think it's a good indication, because most of those patients will die not of local regional disease, but more of metastatic disease. And I would be reluctant after chemoradiation to operate on full chemoradiation in those patients with persisting N3 disease.
Right. Got an interesting question from Dr. Willamata, who's asking, do your recommendations also apply to patients with oncogenic driver mutations, such as EGFR or ALK?
Yeah, as I mentioned in the last study, there's not so much information or studies looking at surgery after targeted therapies. But yeah, I think you can have a lot of inflammation, because this week we operated a patient after targeted therapy. I had to do a lobectomy, but it was a quite difficult operation. Those targeted therapies give a lot of inflammation around the hilum and the pulmonary artery. We have less information about it, but I think it can be an indication for salvage surgery when there is progressive disease not responding anymore to targeted therapies. And you know, we now have the results of the NEO-ADAURA study, showing that you may obtain a major pathologic response, but to be honest, the pathological complete responses in the NEO-ADAURA were quite low, and lower than after chemoimmunotherapy. So probably there will be a lot more patients undergoing salvage surgery after neoadjuvant application of targeted therapies.
A question from Pierluigi Filoso, who's asking about advice on the management of septic patients after chemoradiotherapy. In his experience, is quite a formidable intervention.
Yeah, those are, sometimes they are nightmares for thoracic surgeons. As the last case I showed you, there was no other option, because the patient was heavily infected. She was almost septic when we operated her. So we had to do a pneumonectomy, which is quite difficult in this case, because we had a tear of the pulmonary artery. So you should really be prepared for the worst scenario. But when a patient is almost moribund, so yeah, you don't have any other options than go in and try to salvage the patient. In this case, probably you noticed we also put in an irrigation system to irrigate the cavity, which was heavily infected with bacteria and fungi. So this could be another option to rinse the cavity. We did it with a betadine solution to avoid recurrent sepsis and empyema, because after, as you know, right pneumonectomy, when you have a septic condition with an empyema and a bronchopleural fistula, this is very difficult to treat. So another thing is to cover the bronchial stump, especially on the right side, with viable tissue when you perform such cases. I have some patients, we had to do a thoracostomy because of persisting infection afterwards. Yeah.
Right. Question from Mr. Will, who's asking, with salvage surgery, do you, in cases where the original or primary tumor has shown a degree of response, do you resect the primary tumor or the footprint of the original tumor that was there when you go in for the salvage operation?
No, for difficult cases, we try to resect what is remaining of the tumor. So, but as I mentioned, imaging is not always very helpful to decide whether there is remaining tumor. Sometimes the PET scan can say this is a region with high uptake, so we expect that most of the tumor is there. But usually we try to resect what is the residual disease because it's already difficult operations. Otherwise, you go for probably more pneumonectomies than you intend to do. We try to limit the resection just to avoid recurrent infections.
Yeah, certainly an extremely challenging situation.
Yes.
Absolutely. As always, more questions than there time for answers, which leads me once again to thank our sponsors, AstraZeneca, Medtronic, and Medela, the Science of Care. Next month in August is going to be the start of a robotic month with advances in robotic bronchoscopy with Professor Thomas Geisel from Zurich, which again leads me once again to thank you, Paul, for an amazing overview on a very difficult topic, and also for your leadership in this field and presidency for the IASLC. I think myself and also the rest of the world are very grateful for your leadership and advances in this field.
Okay, thank you very much, Eric, for your
Thank you
kind
very much. Have
comments.
a good day.
Yeah.
Thank you. Bye-bye.
Bye-bye.